we've had a quick whistle-stop tour of the key bits of infrastructure. I'm just going to finish this first session, if I may, by returning to the broad themes that Stephen set out at the beginning, because that's really what the wider conversation today is going to be about. How do we get to a point, and I'm thinking here 5 or 10 years' time, where we've built something which is really recognised for its health and care research excellence, driven by the needs of our patients and the public and the services that they use. And when we put the programme together for today, you can imagine there's always a bit of anxiety, are we going to get lots of good stuff for people to talk about or not? I've been genuinely blown away by the diversity and quality of the research on this programme today. But I think we nevertheless are in a place where historically there has been a problem in Sussex with lack of strategic alignment around health and care research. The people who we are now talking about in this partnership have existed a long time and have tended to move in their own tracks, as it were, with very little working between themselves. And this has led us to a place where some of these data for Kent are in Sussex rather than specifically Sussex, but the message is the same. We have really underperformed in terms of our health and care research. So population across these counties, 8% of the country, about 4% of the research participation in the NHS, second lowest for any region in England. About 20% of the research studies in our region are led from our region, and again that's the lowest figure for any regions in the country. And what that means basically is we're doing other people's research addressing their priorities, not our research addressing our population priorities. We've done really poorly with things like NIHR Senior Investigator Awards, Experimental Medicine Infrastructure Awards from NIHR. These are the big ticket kind of bits of physical infrastructure NIHR pay for. We do, of course, have the ARC and the Academic Health Sciences Network. Some of you may be aware we've recently lost our Regional Research Design Service as part of the reorganisation of that part of support from NIHR. But these various facts, I would go as far as to say, mean we have failed to deliver, fully at least, evidence relevant to our population, health and services. I think really importantly, we haven't given a voice to our population in setting research agendas. If you're a member of the public in Manchester or Oxford, there's plenty of opportunity for you to stand up and make your voice heard, and we've not really provided that at a strategic level yet. We failed to make distinctive, excellent contributions nationally or internationally. So, where across the globe, what people recognise us for across the globe, we need to start thinking what those things are. We failed to effectively link the evidence needs from our population to the evidence we generate and implementations, which is really what it's all about. As Stephen said at the beginning, how do we get the evidence and actually feed it through into changing care and improving outcomes? We failed to achieve economic benefits, which we know are allied to strong health and care research, and we failed to support and benefit from the success of our academic partners. So that's really just to make the point that universities have got a lot to gain here if we get this stuff right. We have a huge opportunity created by the creation of the integrated care services. So one of the things that Sussex Health and Care have done, of course, is to take the NHS long-term plan, which sets the national priorities for the NHS, the wellbeing strategies that existed previously in this region, and produce their own strategic vision, improving lives together. And that really gives us a framework, if you like, for thinking about what are the things that our population really needs. The creation of integrated care boards under the Health and Care Act creates a statutory responsibility on them for research. So they can't wriggle out of it. They've got to help us do this stuff. And so it's a huge opportunity for us to seize upon that and get together. So there's plenty of reference points we can draw on. So both the NIHR, who fund almost everything we're doing in this space, the Department of Health, have set about very recently stating what they want people to do. In other words, what they're going to pay for. We have, as I say, the NHS long-term plan and Improving Lives Together, which tell us what our local needs and priorities are. And then in March of this year, we had published by NHS England this document, Maximising the Benefits of Research, Guidance for Integrated Care Systems. And it basically says integrated care systems have to have research and care, a health and care research strategy. And they draw particularly on Bristol Health Partners as an exemplar of how to go about doing that. And so at lunchtime today, I'm really pleased to say we've got Professor David Winnett coming online, but to speak to us about the Bristol Health partners' experience of developing these themes and how they went about doing what we're going to try and do over the next few years. And what this document says, if you read it, is, in fact, from my point of view, manna from heaven, if you like, because it essentially describes the HRP. So it says you need leadership for the Integrated Care Board, Exhibit A. Research steering board. You need to build on the infrastructure we've been hearing about. You need to support delivery of research. You need to map research strengths, networks, and activities. You need to address universal priorities reflected in research needs. You need to enable multi-organisation solutions to complex challenges. That's getting us all together to align behind challenges that we can't solve alone. You need to involve patient, public and service users. You need to ensure everyone can participate. You need to harness health data. You need to use evidence for planning, commissioning and improving care. And you need to focus on the workforce that you've got. And I've highlighted those three in red because that's really what we're here to talk about today. How do we get together and think about what are our strengths and activities, what are the universal and local priorities, and how do we enable multi-organisational solutions. And it wasn't completely by design, but you'll notice that all the sessions we've got today have got really strong input from different partners across the organisation. They're not themes where there's just one person who cares about them. So we had a meeting of the board a few weeks ago, as Stephen alluded to, and we talked about what themes we could all get behind as partners. And none of this is rocket science. They're the obvious things we've been talking about. How to address health inequalities, how to improve the prevention of disease, how to improve what we're doing, research into sustainable healthcare, how to improve clinical outcomes, and how do we harness the opportunities of data and digital transformation that's going on in the NHS. And then there are cross-cutting themes which are clearly going to be present in everything we do. How do we make our research data-enabled? We're not going to put an order of magnitude on the research we do by doing things in the same way we've always done them. We've got to do things differently, building on this new digital NHS. And how do we make sure our workforce, the full workforce, is supported to do these things? So I'm going to leave that slide up because it's probably too small for me to, well, you can see it, but too much for me to read out. And we've just got a couple of minutes. I thought I'd stop there and just give people a chance to ask some questions about the first session before we get stuck into the really fun stuff in terms of the science. Please. I don't know if I've got it working.
I can use the microphone, it's fine. Hello, my name's Alan Sutton. I'm a member of the new advisory board, the Public Advisory Board. And I'd just like to say how much that can contribute to what you're trying to achieve here. The cross-party collaboration across all the system is really, really important, and I'm delighted that I've got colleagues here who I've known for 5 or 6 years. I've got one of my research champions from the University Trust here. I've got Dave, who is the lead governor for the Surrey Community Trust, the Royal Surrey. I myself am involved in the Community Trust and Brighton University Hospital as a research champion. And your commitment to involve the patient voice is so important. It really helps research. Recently I was at Barts Hospital on a science course for cancer patient advocates, and working very closely with the people who were doing the research there. We had the lectures in the morning and lab experience in the afternoon. And the most powerful part of that course were the 16 or 17 people on it who were cancer survivors. They were people there that had lived experience. They were from right across the globe. So, Stephen, you know, your impact here, if you get it right, will go right across the globe, because we have those networks, we can talk to people, and we can help you with research. So, I'm really delighted to be a member of the advisory board. I know there's my friend here as well, who's also one of my research champions at the Community Trust, who's a member of the board. And I'm just delighted that we can come in and contribute. So, thank you for the first session. Thank you very much, Martin.
Thank you.
Thank you very much, that's fantastic. Good question back. Go for it.
Hi, I'm from East Sussex County Council, and thank you for the introduction this morning. I just wondered, from some of those of you that have spoken this morning, how would you want local authorities to support your endeavours with this?
So the question was, how do we want local authorities to support and be involved? Really to come forward and join us, thank you. And so we do now have local authority input on the executive, which has been fantastic. You know, I guess the result of the history that I told you is that we find it quite hard to navigate this landscape. So I'm primarily a secondary care clinical academic, and so my knowledge of what's out there in the local authority space is limited. And so really it's coming forward and being willing to join these conversations and signpost us really. So thank you.
Shall I jump in?
Yeah, good.
Yeah, and just to add to that, I think from an integrated care system point of view, I've involved the Directors of Public Health, and they recommended Jackie Rock from West Sussex County Council join the executive, because I said we need local authority involvement in this. So I think we're at the foothills, there's more to do, but I think it's not lost.
Mood.
I have mood on the next session. Just a question, so this is great, of course we need to look and question our systems. The struggles we sometimes have is, although this all looks integrated, the reality is when we actually work is it's not integrated. Secondary care have their own budget and their own priorities. Primary care have their own budgets and their own priorities. And when you try to bring things together, I'll give you an example. I've tried to build a system where I can deal with children with hearing loss and the most disadvantaged children in primary care, where I can provide expert. But I was told, no, it's not possible, because who's going to pay for that? Primary care won't pay for it, secondary care won't pay for it. So I think we probably need to look at how we can be agile, probably some seed funding to get this done, rather than us having to battle, those sorts of things. I'm sure you've thought about
No, absolutely. So interesting. I'll just answer very briefly, mate. I mean, so absolutely get that, and in a way, that's why we started this session with what you might consider to be a bit sort of boring nuts and bolts of the infrastructure stuff, rather than just luxuriating and people talking about interesting science, because we've got to get that right. And that's going to be a sort of staged process, and getting buy-in to these key bits of infrastructure through memorandum of understanding, through contractual relationships about how they're funded, will take us on that journey. The ultimate destination will be something that looks like an academic health sciences centre, where a lot of these boundaries are properly broken down and there are really joined up budgets. And a lot of those organisations are actually quasi-independent with self-running, with partnership subscription models, for example. But that is a really long journey. And one of the newest ones is Bristol, which is why we've asked them to talk to us about how they went on it. But it's probably a 5 or 10 year journey. But we're not, so don't think we're glossing over it. It's difficult, but has got to be done. Please.
I just agree. I'm sorry, I can, sorry, I'm lip reading, so I can't. It's really difficult. I think I so agree with the whole idea that people, the deaf community out there, have real problems. Taking this for instance, you come in here, you don't want to list all your disabilities, but you presume that there will be some sort of microphone. So, but the deaf community then never picked up until they're so bad, they're referred by school to the hospital. It's so difficult, or unless they've got a relative who has a hearing loss, and they will know the place to go. It really needs to start, the recognition needs to start much earlier at GP level, and therefore you save so much money in the end, because people learn much easier if their hearing loss has been mitigated. So
I would just say this is exactly why we need that sort of input in the work we're doing about research engagement. And building these sort of networks which genuinely try and get into the really hard to reach places in the community. And it's difficult, we need to try and I'm really sorry, I think the time is so short. Can we take more questions later on? Is that all right?